All right. Good day, everyone. I'm Dr. Danelda Leverick, and it's my pleasure to welcome you here to this important session in our INCAM Integrative Health webinars. I am the past chair of INCAM and the current lead on the Members Resources Committee. And I'm also the Associate Director of the Center for Integrative Medicine in the College of Medicine in the University of Saskatchewan. And as a network of individuals with expertise in integrative health and healthcare, it's our honor to bring education and collegial professional relationships together to support the work of researchers, practitioners, and educators benefiting the well-being of Canadians. So thanks to all you network members for your attention and for your engagement in this community. It's also my pleasure now to introduce our guest speaker today. Dr. Monique Aucoin is a naturopathic doctor and a senior research fellow at the Canadian College of Naturopathic Medicine. She is an adjunct professor at the University of Guelph in the Department of Human Health and Nutritional Sciences. Her clinical practice and research work are focused on the role of diet and nutrition in the treatment of mental illness. Additionally, Dr. Aucoin is engaged in research on the use of evidence in the naturopathic profession. Dr. Aucoin is an instructor at CCNM, an INCAM board member, and a review editor for the journal Frontiers in Nutrition. And Dr. Aucoin, we are delighted to have you present today. We're looking forward to this valuable session and this valuable information. And I'm going to, in a moment, turn the mic over to you. And I will again say thanks everyone for joining us. Please feel free to ask questions at the end of this session, I think, Dr. Aucoin. And also please feel free to send us a note and let us know any questions that you have or any follow-up that you desire. So thanks again for joining us, and thank you, Dr. Aucoin. The floor is yours.
Great. Thank you so much for that introduction, Danelda. So the title of my presentation today is Supporting Evidence-Based Practice, Results from a Survey and Co-Designed Continuing Education Course for Canadian Naturopathic Doctors. My collaborators on this project are Dr. Kieran Cooley, Dr. Matthew Leach, and Dr. Jen Newton. So evidence-based practice has been defined as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. It's often visually represented as the meeting point of these three pillars: best research evidence, clinical expertise, and patient values and preferences. The idea of evidence-based practice emerged out of concern that research evidence was not impacting clinical decisions in a timely and consistent manner. Some of the benefits attributed to evidence-based practice include better health outcomes, better patient satisfaction, and lower healthcare expenditures. But there's a concern that there is suboptimal use of evidence-based practice in a wide range of health professions. Pretty much all of them have this concern has been expressed. Within naturopathic medicine, there's been calls from within and beyond the profession that there is a need to improve the use of evidence-based practice. Naturopathic medicine, as some background, is a healthcare practice that involves the blending of traditional and natural therapeutic strategies with modern scientific knowledge in order to prevent and manage health concerns. There's a set of guiding principles and philosophies, including those like treat the whole person, treat the root cause of disease. It's regulated in 6 Canadian provinces. In terms of our understanding of evidence-based practice within the naturopathic profession, there's some qualitative data that dates back into the 2010s. There was a 2017 study that was done in the United States that reported a shift from hesitancy to cautious embrace among naturopathic doctors, although they did recognize a large diversity in attitudes. A study of Australian MDs found that there was concern that traditional knowledge could be undermined by scientific evidence. And an international survey of ND students and faculty reported a need to find balance between traditional and scientific knowledge. However, up until recently, there hadn't been a quantitative analysis of evidence-based practice attitudes within Canada. So myself and my team members, Dr. Leach and Dr. Cooley, we completed a survey of Canadian NDs. This was a national cross-sectional study. And our objective was to explore evidence-based practice attitudes, use, and skill, along with barriers and enablers. Our inclusion criteria was NDs in Canada, so pretty broad. And as our assessment tool, we use the validated eBase questionnaire. This is a tool that's been validated to assess these constructs, attitude, skill, use, about evidence-based practice. And it's been used by researchers in a wide variety of professions, complementary and integrative professions globally. So it allows for comparison with other professions and other jurisdictions. We had 252 participants agree to take part in the survey. And here are the results. We found that the evidence-based practice attitude score was an average of 34 out of 40, which was considered high. The evidence-based practice skill score was 44 out of 65, which was moderate high, and evidence-based practice use score was 13 out of 24, which was moderate. And these aligned with findings from other complementary medicine professions. When we looked at the use of evidence in clinical practice, we see that most participants reported that either a large or moderate proportion of their clinical practice decisions were based on scientific evidence. In terms of the sources of evidence that participants reported using, these were diverse. They included research, along with traditional knowledge and patient preferences. So this really shows that the practice being done by Canadian NDs was really consistent with that definition of evidence-based practice that we started off with, that visual on the second slide. The barriers that were reported, barriers to evidence-based practice use, included lack of time, lack of evidence in naturopathic medicine, patient preferences for certain treatments, lack of resources like internet or online databases, insufficient skill in locating, interpreting, and appraising research. They did not find that lack of interest, support, or incentive were significant barriers, and the barriers cited were consistent with other health professions. In terms of enablers, the ones most reported by the participants included internet in the workplace, online databases, particularly free ones, the ability to download full text journal articles, online evidence-based practice materials, critical appraisals tools, and tools to critically appraise topics and assess and assist with critical appraisal. One of the most important findings that I took away from the survey results was that 93% of the respondents were interested in learning or improving the skills necessary to incorporate evidence-based practice into their clinical care. So although the skill and use were all moderately high or high, there was awareness that there was opportunity for improvement, and the participants were aware of the opportunity for improvement, and they were interested in correcting these deficits. Previously, there had been no coordinated efforts to support evidence-based practice among NDs, but based on these survey findings, we felt that this was important to do. So moving on to the next project that we did to build on this work. We decided to undertake an evidence-based practice continuing education course for Canadian naturopathic doctors. Our primary objective was to assess the feasibility and acceptability of a co-designed pilot EBP continuing education course for Canadian naturopathic doctors. And our secondary objective was to assess for changes in evidence-based practice attitudes, skill, and use as a result of participating in the course. We divided the project into two phases. The first was the co-design of the course, and the second was the delivery and evaluation of the course. In the first phase, we recruited NDs to take part in 3 focus groups. The topics that we asked them about were their definition or understanding of evidence-based practice, their learning needs, interests, and preferences with respect to a continuing education course on evidence-based practice. And we conducted 3 groups where we stratified the participants based on their baseline use of evidence. And this was an effort to minimize tension within the focus groups. We recognize that within the naturopathic profession, there are diverse views on the role of evidence, and we wanted the focus groups to be a positive, supportive environment where people felt comfortable disclosing their views, and that there wasn't going to be too much conflict or tension. Our target sample size was 18 to 24 participants. Our methodology was a semi-structured interview, and our analysis plan was to use thematic analysis. In total, we received 75 inquiries when we advertised broadly to NDs across Canada. In terms of the NDs that were eligible and willing to attend a focus group, in the end, there were 22 who were available at the times that we had scheduled. Of these 22, you can see that 12 of these were from the high evidence use group. So there was more of an interest from those people who were already using a high level of evidence at baseline. And here, one of the themes that emerged from the focus group in terms of understanding their interests was an interest in improving evidence-based practice skills. So one of the main interests that was mentioned quite often was an interest in improving the efficiency of searching for evidence. So participants were curious about pre-synthesized evidence, overcoming cost as a barrier to access, improving their PubMed searching skills. They're interested in resources and new databases. Additionally, they were interested in critical appraisal, understanding sources of bias, methods of communicating research findings, and skills for ND-created research. We had some quotes, interesting quotes that we will highlight just a couple of. The first says, "I really loved the research class at CCNM, but I really forgot a lot of the key points from that class. I wish I could go back and refresh myself on some of those things." This was a participant from group 1, the high evidence user group. Another quote regarding pre-synthesized evidence: "Although being able to appraise is absolutely very important, I'm not going to spend hours of my week doing it. I don't have time. So for me, learning some of those really good resources that would be trustworthy." Again, this is from the high evidence use group. Another theme that emerged from the data in these focus groups was an interest in balancing scientific evidence with other factors. So participants weren't interested in looking solely at just the research, but they wanted to think about research within the context of naturopathic medicine. So there was an interest in viewing research with a naturopathic medical lens. A value of clinical experience was emphasized. They were interested in thinking about scientific evidence within the context of the principles of naturopathic medicine and the therapeutic order. They were interested in informed consent and patient autonomy, individualization of treatment plans versus protocols, extrapolating findings or dealing with lack of evidence, and as well as the value of non-RCT evidence or other sources of evidence, and a preference for the term evidence-informed versus evidence-based medicine. This was a quote from one of the participants in group 3, which is the low evidence use. This person said, "So it's this whole dance all the time. And for me, we have to find out how everything fits together versus deciding what to throw out and what you're keeping. And that's what gets us into trouble, as too often the discussion has been, in order to advance the profession, we need to move to evidence-based practice. But they word it in such a way that you lose your principles and you can't do both. And it doesn't have to be that way. It doesn't have to work that way." So an interest in really thinking about evidence alongside those principles of naturopathic medicine. So in terms of the other data reported by in the focus groups, all of the groups were interested in 1-hour education sessions and 3 to 5 in total. They were interested in live sessions with recordings in evening times, and they were interested in practical exercises. That was common between all groups. There was also some information that was unique to different groups. In the high evidence users, there was an interest in increasing evidence use, which was interesting. These people were already using the most evidence, and they were interested in doing it more often. They emphasized prioritizing scientific evidence and pre-synthesized evidence. And although not directly queried about it, they were highly supportive of evidence-based practice. Among the low evidence users, there was an interest in a broad range of evidence sources, including traditional knowledge, elders, patient expertise. They were interested in interpretation of research in combination with naturopathic philosophy. There was some interest in the course, although many had caveats. And there was some interest in increasing use, although many were satisfied with their current level of use. Many felt that they would like to improve their efficiency or their skill level while still maintaining that current level of use. And again, although not specifically asked, there were somewhat more cautious views of evidence-based practice expressed. So overall, we found that the focus group data suggested a high level of understanding about the evidence-based practice framework. The views were largely favorable, and there was a relatively high interest in the proposed course. So this is the course that we designed based on this feedback we received. We created 5 weekly sessions, 1 hour in length, and the sessions were as follows. The first was the basics of reading scientific evidence, then finding, appraising, applying scientific evidence, and advanced topics. So moving on to phase 2, this was the delivery and evaluation of the course. In terms of recruitment, we spent 3 weeks recruiting participants to enroll in this course. It was a relatively short amount of time, but we were on a tight timeline. And we advertised through the alumni e-newsletter and social media. In terms of sample size, we did not conduct a formal sample size calculation, but we were targeting 55 to 70 participants. Eligibility was NDs in Canada who had an active license and were willing to provide informed consent. And these were the outcome measures that we planned to assess. Our primary outcome was feasibility, which we planned to measure based on enrollment. Acceptability, we wanted to measure based on attendance and our satisfaction survey. In terms of the secondary outcomes, we plan to assess evidence-based practice skill, attitudes, and use using that same questionnaire that I mentioned before, the e-based questionnaire. And we wanted to objectively assess evidence-based practice knowledge as well. We were a little bit worried that you don't know what you don't know, and that people might report a higher level of evidence-based practice skill at baseline, and then realize there was a lot about scientific literacy or research methodology that they didn't know, and possibly report a decrease in their skill simply because they learned more about all the information that was out there. So we wanted to try and objectively assess evidence-based practice knowledge. And to do this, we created an evidence-based practice quiz. This was a multiple choice test that we hoped would more objectively assess their skill level. And lastly, we collected some demographic information. So at baseline, and then after the course, we administered the e-based questionnaire and the evidence-based practice quiz. And as well, after the course, we administered the satisfaction survey. At 2 months follow-up, we repeated the evidence-based practice use subscale, and that was meant to capture changes in use that might have happened after the course. We felt that during the course, as people were acquiring these skills, they might not have a chance to put them into practice right away. In terms of data analysis, we plan to look at the satisfaction survey using thematic analysis. We plan to look at changes in the e-based subscores and quiz using a paired sample t-test when normally distributed and Wilcoxon signed rank test when not normally distributed. And we plan to do some exploratory analysis, looking for correlations between changes in the secondary outcomes and demographic or attendance data. In terms of missing data, we plan to use last observation carried forward. And here's what we found. We had 81 participants register for the course. Of those, 12 declined to participate in the research component and 8 were ineligible. So this left 61 participants who completed the baseline assessments. Following the course, 57 of those completed the post-course assessment and 4 did not, but all of those participants were included in the analysis. Here is our attendance data. Along the x-axis, we have the number of sessions attended from 0 to 5 and the number of participants. And you can see that 64% of the attendance of the participants attended 4 or 5 sessions. With respect to satisfaction, we asked people if they were satisfied with the course and if they would recommend it. And we found that 89% said they would agree or strongly agree with the statement that they were satisfied. In terms of the themes that emerged from the open text questions in the satisfaction survey, we asked people, we had responses related to the level of difficulty, and these were sort of contradictory. Some people told us that the most helpful lecture was the basics, some said the advanced, and some, in terms of the least helpful, some said the basics were too easy, and some said the advanced was too difficult. So really, the suggestions for improvement were, and this was consistent with our interpretation of those results as well, was that there was a need for 2 separate courses at either a basic or an advanced level in order to meet the wide range of needs. We found that the needs of our group were quite broad, and it was challenging to meet all those needs with one course, and that dividing it up might be a good strategy for the future. In terms of the content, people appreciated the topics of critical appraisal, searching for evidence, risk of bias, and statistics. Some reported the least helpful was the application to naturopathic medicine, although as we saw in the previous, there were highly different views on that. In terms of suggestions for improvement, there was an interest in more statistics, more cases and example articles, and more content about generating research. In terms of the format, people liked the interactive components, the practical exercises. They were divided on the online delivery, and some felt the pace was too fast, sort of consistent with that earlier statement that it was too difficult for some. There was an interest in increased time for practical exercises, longer sessions, and more time for questions. In terms of resources, there is an interest in quizzes for each module to assess comprehension and assignments and homework, which I was rather surprised about, but I think that this spoke to a really genuine interest in engaging with the topic and learning in a meaningful way. All right, so moving on to the secondary outcomes. When we looked at the e-based scores from pre-course to post-course, we did not see any changes in the belief score or in the use subscore, but we did see a significant increase in the skills score. In terms of the use of clinical evidence, this figure shows the percentage of evidence, the number of participants using none, a small portion, very small, small, moderate, large, or all of their clinical decisions based on evidence. The green column is pre-course, gray is post, and blue is at follow-up. And as you can see, there's a decline in the number of people using a very small portion of evidence and an increase in the number of people using a large portion of evidence. In terms of the quiz score, so this was our objective attempt at measuring evidence-based practice knowledge. The green bar is the pre-course score. And we have the score from 1 to 16 and the number of participants achieving that score. The blue is the post-course score. And we can see that we had a number of sort of moderate scores in the prior to the course. And after the course, we had some higher scores. So the mean score increased from 10.8 to 12.1, and this was statistically significant. In our exploratory analysis, we found a weak positive correlation between attendance and change in quiz score. So the more sessions people attended, the greater the increase in their quiz score, and a moderate inverse correlation between baseline quiz score and change in quiz score. So the participants who scored quite high at the beginning didn't improve their score as much. And this speaks to sort of a ceiling effect. In hindsight, we can see that maybe we could have made the quiz a little bit more challenging, as some participants didn't have a lot of room to improve on their quiz scores because their knowledge was quite high at baseline. So moving on to some discussion and conclusions. So this project had some strengths and limitations. In terms of strengths of the survey, we attempted to reach all Canadian NDs. We put a lot of effort into trying to disseminate the opportunity to participate through social media and many of the provincial and national associations. And we use this validated e-based tool, which allows for comparison with other health professions and other geographic locations. With the course, we used a co-design process, which allowed us to engage our primary stakeholder, which was practicing naturopathic doctors, and involve them in the design process right from the beginning. We did this in hopes that we would create a course that was relevant and interesting to these members and something that they would want to participate in. We also included all participants in our analysis in an effort to avoid biasing our findings by including only those who completed the course and might have had more favorable views. In terms of limitations, we recognize that in the survey, we had a relatively small sample size relative to the number of NDs within Canada, and it's possible that there was a self-selection bias. Potentially, those who had stronger views about evidence-based practice may have been more likely to participate. Another limitation is that the survey included only self-reported data, and this self-reported information may not accurately reflect actual skill or use of those participants. With respect to the course, we used pre-post methodology and lacked a control group. And there's a possibility, again, of selection bias. Those people who are more keen about learning about evidence-based practice were likely the ones who came out to take part in the course. And we must keep that in mind when interpreting the findings. So with respect to our primary outcomes, we found that co-design and delivery of an evidence-based practice course for Canadian NDs was both feasible and acceptable. There was a high level of interest and engagement and a high level of satisfaction expressed by the participants. In terms of secondary outcomes, there was an increase in self-reported skill, an increase in objectively measured knowledge, and in terms of use of evidence, there was no change. However, we wanted to note that it was relatively high at baseline. Among the participants in the course, their baseline use of evidence was 20 out of 24. So again, this lack of change might reflect the ceiling effect. There was not much room for improvement as these people were already using evidence-based practice quite a bit in their clinical work. As well, evidence-based practice attitudes did not change, but again, these were relatively high at baseline, and there's evidence documenting a challenge in this area, that evidence-based practice attitudes can be quite difficult to change. The project also gave us quite a bit of meaningful direction for the future. We found that there was a need for different levels of difficulty, that it was hard to create a course that met the needs of everyone within the profession all at once. There was a really significant interest in more practical exercises, that people wanted to make this course hands-on and interactive. We're in the early stages of planning for next steps, including offering a fundamentals course to Canadian NDs, as well as considering opportunities to collaborate and offer a course for American NDs. And now we have some time for questions or discussion. I'd love to take any questions that there are as well. I'd love to hear from others either on this call today or viewing the recording. If you're interested in understanding the evidence-based practice, attitude, skill, or use of your profession, or opportunities to support your profession in engaging with evidence-based practice, I would love to collaborate or explore opportunities to deliver a similar project. So please don't hesitate to reach out. So are there any questions today?
Thank you, Monique. Thank you so much for sharing this information, this important information, and thanks also to your team for engaging in this really cool project. I have a bit of questions myself and comments, but before I do, I'd like to open it up to those who are present. Does anybody else have questions or comments for Monique? And perhaps while you think about yours, I'll share my questions and comments if I may, Monique. My first question was going to be about your interest in next steps around collaboration with other professions, and you've already answered that in this slide. So just from a practical perspective, if other fields, other professions were interested in collaborating with you, what would be their next steps?
Right. Great question. So I think first off would be to look at what exists within the evidence related to that profession. So having a look at what's been done already in terms of evidence-based practice. If there's an opportunity to do something like repeating that e-based questionnaire as a survey, I think that that would be a great place to start in terms of understanding evidence-based practice, skill, and use within other professions. And if there is an interest in building off of it, there could be an opportunity to do a similar project like the co-design and delivery of a course. And again, the purpose of that co-design is to really identify what are the unique considerations for that profession, what's going to make the course relevant and interesting so that it is tailored to meeting those needs. So I would say delivering a similar project, I think would be a great option if that seems appropriate based on what's been done so far.
Mm-hmm. And would you say, and also, I'm thinking sort of the entire scope, because you've done such an excellent job today in presenting your work right from sort of inception through to your initial study into the creation of the educational component and then the assessment of that. So for other professions, I'm wondering, in terms of collaboration, can you envision an opportunity of helping people move through those very same phases?
I think so. I think that we've gone through that process, and rather than other groups reinventing the wheel, if we can sort of share what we've learned about that process of going through these 3 steps, if it seems relevant to use that same process, then I think that that's a great idea.
Okay, terrific. I just have one more short practical question. Tell me about that e-based questionnaire, if you would, please. When was that designed and validated?
Oh, that's a good question. I believe it was like 2015 or 2017. I can get back to you on the exact one, but it was done by Dr. Matthew Leach, so one of the collaborators on this project. He's located in Australia at Southern Cross University, and he has he's done similar surveys with other complementary medicine professions around the globe. He's not just complementary medicine, so nursing professions, but also yoga therapists and chiropractors and herbalists, a whole range, osteopaths, a whole range of different professions. And by using that same questionnaire, it allows for comparison and sort of comparable data that we can then look at for those different professions.
Agreed. Yeah, terrific. Okay. I have other comments and questions, but again, I want to give others an opportunity. Does anyone else have a question for Monique or comments about the project? Or comments about the way this fits into to your own work is always a great conversation as well. Michael.
Well, I'll try here. And this is a half-formed ideas. This is absolutely fascinating, and I think it's just a great job that this research team has done.
Thank
I'm
you.
just thinking on a phenomenon that I think is becoming quite clear right now, which is that the evidence-based medicine movement and the complementary and integrative medicine movement have really evolved over roughly the same time frame. And a fair bit of attention has gone over the years to the how to teach and learn complementary medicine. Most of that work that I've seen, at least, has been in the context of teaching to medical students. Nonetheless, there has a fair bit is now known about how to teach and learn about complementary and integrative medicine. And there's been a whole other conversation going on about how to teach the teaching and learning of evidence-based practice. And it just seems to me and then there's definitely, I think the observation here that multiple different stages of learning. I think that's enormously important here. It seems like the first stage is simply learning how to access and locate and use all evidence and so forth. And then there are those much more nuanced challenges about how to integrate the three sources of information: the patient's voice, the clinician's voice, and the voice of the scientist. I think it's just a very rich area for high quality educational research and the potential for engaging with educational researchers on doing this. We're familiar with, I think, a lot of these issues that have come up here, particularly the one about different stages for different stages of learning and so forth. So all I can say is it's absolutely fascinating. I think you've done a fantastic job here. I think it's a really important area and really rich in terms of intellectual challenge and opportunity as well. I think it's just great.
Thank you so much for that comment. I appreciate it.
Yes, thanks. Thanks very much, Dr. Epstein. Kieran, Dr. Cooley.
Yeah, thanks for an amazing talk, Monique. Always great to hear you speak, and biased, of course, but I think wonderful research going on here. I'm gonna ask you more of a totally opinion-based question, or something that maybe didn't come across directly in some of the interviews with participants, but in this like clinical practice space, there's often this assumption that more use or attention to evidence is appropriate or even better, right? And I was just curious if you heard from participants around what the right recipe, proportion, degree of engaging in the literature was reasonable, feasible from participants' perspectives, and then, you know, how does that sort of mesh with your own understanding of EBM? Tough question, sorry.
Yeah, it is a tough question. And I think that is important to think about. Like, I think our automatic assumption is we should aim for that highest score, but you're right, that might not necessarily be appropriate. And what we heard back from participants really varied quite a bit between those sort of stratified groups, and kind of in the opposite way that we would have expected. So those people who were using, sorry about that. The people who were using a high level of evidence at the beginning were very keen to learn more and use evidence more. But the people who were using the lower degree of evidence at baseline were less interested in adding more. So I think, it depended on who you asked in terms of that question. There were some that felt that there was an appropriate amount and that adding more was not going to enrich the quality of their care, but they were still interested. Some of them were still interested in the course because they wanted to get better at it. So they didn't want to necessarily use research more, but they wanted to be more scientifically literate, more skilled at navigating databases so that they could do that more quickly, or be more scientifically literate. So when we're hearing about new studies in the media, that they're able to be a little bit more critical and engage with thinking critically about that research. So certainly some said more is better. Some said, let's not necessarily do more, but let's just do it better. And I think I probably fall into that camp personally, there's an amount, but then there's also the quality of that engagement that is important.
Kieran, sorry.
No, well, I was going to say thank you. I mean, yeah, a great response, and thanks for sharing not just your own sense, but the participants' sense as well. And then I guess it does kind of dovetail back to Donelda's earlier question. I know so much thought has gone into this needs assessment, environmental scan, the co-design component, the delivery and evaluation. Now, are all those steps, like of all those steps that you took along this path, can you speak to maybe what was the best starting point? Do you have to start in the same spot that you did in order to, achieve what you're hoping to, either for more work in this space or with other professions?
I think the environmental scan, in terms of assessing needs, I think is a very good starting point. It's a very natural beginning step, but I don't think it's necessarily essential. When we look at, as I mentioned, the evidence across professions says that all health professionals are using evidence suboptimally. Within all professions, there's opportunity for improvement. So I think that it's somewhat safe to assume that many professions can benefit from evidence-based practice continuing education. I think it's important too to consider, as Dr. Epstein mentioned, sort of the growth of naturopathic medicine and alongside the growth of evidence-based practice at the same time. We know that evidence-based practice involvement within the curriculum of complementary medicine training has changed significantly in the past decade or two, with more recent graduates getting more training in evidence-based practice, whereas practitioners who graduated a decade or 2 decades ago having received much less training in this area. So certainly there's a body of participants within each profession that went to school at a time when evidence-based practice was less of a component of the curriculum. So there's very likely an opportunity to improve on the skill within for those members of the profession, whereas newer graduates may have received more training. But as I said, it varies based on the length of time in practice.
Yeah, great discussion on both of you. I want to just say, and I want to reiterate again, just how very cool I think this project is. And on a couple of different levels, Monique, and not the least of which is this practical value, and the practical value from a research perspective, from an education perspective, and from a practical perspective. And I just wanted to share my enthusiasm for the good design. For those of us who'd like to nerd it out on the solving weaknesses in previous research attempts, in asking questions and gathering data, analyzing and interpreting, drawing conclusions, and offering implications. I just want to stress how important I think that is for the benefit of diverse groups, and you've done that, and in innovative ways. I'm just thinking practicality. Your objective outcome measure with the quiz. What a cool solution to some common weaknesses. So thank you for that. And I just want to share my enthusiasm for the possibility of collaboration, of using this well-designed process, and how that could benefit others within this network. And this is what this network is about, is collaborating and solving problems. So I just want to commend you again on that, and I want to encourage our other network members to reach out and see about possibilities. And the last thing that I will say, sort of the other level for me around why I think this project is so cool, and I think there's certainly lots of us who again like to expend lots of mental energy on this sort of overarching topic. Your topic, embeds all these amazing, thought-provoking aspects of evidence and sources of knowledge and ways of knowing, and the principles and the values and the integration of these things within complementary and traditional and integrative medicine and integrative health and integrative health care. So this is to me, it's a fascinating topic. And I think, most of us in the network and most of us in the overarching field find ourselves forever drawn back into these very engaging topics, and it never ceases to amaze me that we have a few moments to think about evidence, we have a few moments to think about knowledge, and we fall headfirst into the importance of increasing our understanding, delving further, broader, deeper into these very important topics for the benefit of the health of the people that we serve, the practitioners that we educate, and for the research work where we ask and try to answer questions. So I'm just sharing that with you, that how important I think this is, and how fascinating of a topic I think that most of us appreciate. So thanks.
Can I add one very brief comment?
Please do.
I'll be very brief. I just want to add there's a benefit that may not have been mentioned in here. Much of this, the focus here was on benefits for improved clinical practice, for improved patient outcomes, and for improved decision making in a clinical context. All of those things are, of course, incredibly important. There's another benefit in terms of, if we can use the word literacy or competency in the principles and practices of EVM, that relates to the overall legitimacy, validity, and respect for the profession. And the ability, the debates are still going on in all different literatures, including the medical literature, about what evidence-based medicine is and what it should be. And the ability to be up to date on those debates, to understand the language, to be able to participate in the conversation, I think is just hugely valuable in terms of enhancing the status of the profession. Not only the individual professions, but also enhancing the status and the evolution of integrative medicine as well. So something we all probably know, but I just thought it was worth mentioning.
Yeah, absolutely, Michael, and certainly, that is the level of discussion and the level of conversation around evidence and sources of knowledge, and the legitimacy and the history and the future of all of these professions within an integrated healthcare system that are so important. And it makes me think that perhaps that is another opportunity for the network. I think we still want to have those discussions, and I think we still want to learn from one another. And as you have said, there's ever increasing opportunity for engagement as we become more knowledgeable, or as we refresh or revise the way we think about these concepts. So thanks very much for adding that comment, because perhaps that's another step for the network, and perhaps that's something that Dr. Aucoin and her team could contribute to. This is a much bigger conversation, and I love it.
Amen.
All right, folks. Well, thanks so much for joining in, and thank you all for contributing to this resource for our INCAM Research Network. It's a pleasure to be able to come together and to be able to record these resources for future for education. Dr. Aucoin, I'm going to give you the last word before I bid everyone adieu.
Perfect. So thank you everyone for your attention. And I also want to thank the Canadian NATUROPAThic Research Fund for supporting this project.
Great. Terrific. Thanks so much. All right. Thanks, everyone. Enjoy the rest of your day. Thanks so much, Dr. Aucoin, for an excellent presentation, and thanks for your team for the great work.
My pleasure. Thanks for having me.
Okay. Bye now.